So it's great to be here in Norway, in Finse, to do some training and test the equipment with Rob, but it also gives us a chance to just ask you a few questions about your work and your association with Rob. So I guess that could be the first question, actually, Greg. What is your job? I mean, what do you do?
So I'm a plastic surgeon.
Right.
That involved 18 years of training to get to that point, to be a consultant.
Okay.
And I specialise doing my training in burn surgery.
Oh, wow.
So I used to run the burn service in London at Chelsea and Westminster Hospital, and that's where Rob came in. Now, the way it works when a patient with a burn comes in is somebody is on call on that 24-hour period, a consultant, and they take primary charge of the incoming patient. So my colleague Jorge Leon Velopoulos was Rob's primary burn surgeon, but I was in charge of the service at that time, and I would have had some involvement in Rob's care, doing general anesthetic dressing changes, looking after him on a day-to-day basis when Jorge wasn't there.
And then, did you actually... Did you meet Rob when he first came in? Were you actually there when he was first brought in?
Meeting.
Yeah, meetings is the wrong word.
Rob would have been in an induced coma.
Right.
I wouldn't have been there when he initially came in, because I would have been not on call. I would have been on a rest day.
Okay.
But I would have met him on rounds the first day that I was back.
Okay.
As part of team rounds. So he would have been in the intensive care unit. I'd have been rounding with the intensive care team, helping to make decisions on a day-to-day basis on his care, whereas Jorge would have been overall responsible for his surgical plan and when he was going to have his operations and what was going to be done.
Okay.
And then obviously as Gaz went through his recovery, moving from intensive care to the rehabilitation side of the acute burn service, I'd have gotten to know him, and through his entire outpatient period, I would have seen him. Our outpatients are all done in one room. So we have 4 burns consultants. We all sit in one clinic and see our patients. So I would have seen Rob in passing for months and months as he was coming back for his outpatient appointments.
And going back to when he was first admitted, and as you and your colleagues worked with him, was anything unique about his injuries? Was anything different about his what had happened to him in essence?
Yeah, there was one enormously different thing with Rob, and that was that he was in Zanzibar essentially without any medical care for I believe it was 10 days. And for the size of burn he had, you would have expected somebody to die from that. Gaz isn't the first person this has happened to, but it is unusual. And what happens is within a 24-hour period, pretty much, if you don't start resuscitating a patient who needs a lot of fluid with that fluid, the body goes into a kind of a shutdown, almost like a protective mode, a bit like hibernation, where the metabolic rate goes very, very low, and you can survive without fluid. It's an interesting problem, because sometimes if we have a patient who comes in with a very, very large burn that you know is not going to survive, if you give them resuscitation in that first 24-hour period, it often prolongs their life perhaps for 2, 3, 4, 5 weeks before they get multi-organ failure and don't make it. But if you make the decision within the first 24-hour period not to give fluid, then they will very often and usually die within that 24-hour period. So what happened with Gaz was he, in Zanzibar, was not given the resuscitation fluid that he would normally have. So he kind of went down, and he went into shutdown mode, but managed to survive for 10 days. Now, if you listen to Gaz speak, he said he felt like he was dying, like he was drifting off. But he had a problem getting repatriated to the UK because, as far as I know, he didn't have medical insurance to be medevaced out. And so when the airline eventually agreed to take him, there was almost an expectation that he wouldn't even make the flight. So he got to Chelsea and Westminster in a very, very bad way. And I mean, I would have to go back and look at his medical records for what Jorge thought, but as I recall, he wasn't expected to survive the first few days, and he did. So I think there is that sort of uniqueness that Rob is an unusual cohort of patients who survived when they weren't expected to.
Now, Rob, whilst he was in Zanzibar, I think he said had a couple of aspirin.
Yeah.
What, I mean, it's a hard question to ask. I mean, just to try to get inside the concept. But what kind of pain are we talking about here? I mean, he must have been off the scale of a human endurance almost. I mean,
yes and no. When your skin is badly burnt, the nerve endings are burnt. So actually, you don't feel a full thickness burn. So people can come in with enormous burns and actually not be in a great deal of pain. The opposite is when you have a partial thickness burn, and actually a large sunburn is one of the most painful burns you can have, or a very large partial thickness scald from, say, hot water, because those nerve endings are alive and it's very, very painful to touch.
okay.
What Rob does recall is having some of his wounds cleaned in Zanzibar without much analgesia to help him cope with it. And so his whole burn won't have been full thickness, but a lot of it will have been. But around the edges of the full thickness burn, or in between, there will have been partial thickness burns that would have been painful. Lying still might not have been that painful. Moving, being touched, being cleaned, which I understand he had done in Zanzibar, would have been unbelievably painful.